morning to one and all, and today we are going to discuss about the management of drug resistant TB. So there are various types of resistance has been used for practical purpose. So these are based on drug susceptibility as well as drug resistance only. So monodrug resistance, that is any biological specimen which is resistant to any one first line anti-TB drug is called monodrug resistance. Polydrug resistance means biological specimen which is resistant to more than one first line anti-TB drugs other than both INH as well as rifampicin. Multidrug resistance means any biological specimen which is resistant to both isoniazid and rifampicins with or without resistance to other first line anti-TB drugs. So we have one more terminal called rifampicin resistance, that is resistance to rifampicin with or without resistance to other anti-TB drugs. And extensive drug resistance, which has been defined as that is multi-drug resistance, that is resistance to both isoniazid and rifampicins with resistance to any one fluoroquinolones like ofloxacin, levofloxacin or moxifloxacins along with one group A drugs presently to either bedaquiline or linezolid or both. So I will come to what is group A drugs later on. And pre-XDR, that is it is defined as it is again multi-drug resistance, that is resistance to rifampicin as well as isoniazid with any one fluoroquinolone resistance is called pre-XDR, that is extensive drug resistance TB. So these definitions has been used in the programmatic purpose for treating the patients of drug resistant tuberculosis. So based on recent anti-TB drug resistance surveillance which has been conducted in India recently, their reports has been available now. So based on this report, any patients, that is newly diagnosed TB patients, so among which the susceptible to all drugs will be 77% approximately, and resistance to any one drugs in newly diagnosed TB patients is among 22.54%. For MDR TB in newly diagnosed TB patients, the percentage will be 2.84%. MDR TB with the second line injectable resistance is about 6.9%. MDR TB with any one fluoroquinolone resistance will be 24.14%. And XDR TB is 2.3%. Whereas in previously treated TB patients, susceptibility to all drugs. This previously treated means they can be failure, default or cured, whatever may be. So susceptible to all drugs is around 63.18%. And resistance to any one drug in previously treated is about 36%, among which MDR TB is 11%, MDR with the second line injectable resistance is 2.27%, and MDR TB with the fluoroquinolone resistance is 20.91%, XDR is 0.91%. So overall, that is both among newly treated as well as newly diagnosed as well as previously treated TB patients, the overall susceptibility to all drugs will be around 72%. And resistance to any one drug will be 28%, among which MDR is 6.19%, and MDR with the second line injectable resistance 3.58%, and MDR with the fluoroquinolone resistance, that is pre-XDR, is 21% and XDR is 1.3%. So this is an alarming one. We have to treat aggressively both as well as newly diagnosed and previously treated TB patients. So this is a simple algorithm for the management of drug resistant TB. So now the program gives universal DST, that is we have to do any biological specimen if collected for tuberculosis evaluation, we have to do upfront NAT test, either CBNAT or TrueNAT, along with resistance to at least fluoroquinolones. So these two results will be available within 15 days, that is universal DST. So based on that, either it is presumptive TB or already diagnosed TB patients and any non-responders. So this comes almost all groups, like presumptive TB means which includes all pediatric age groups or people living with HIV, extrapulmonary TB sites, or smear negative or smear not available with X-ray suggestive of TB. Whereas non-responders groups, those who are already on treatment, they have DRTB contacts or previously treated TB patients or TB HIV co-infections or any newly TB diagnosed patients. So almost all patients who have been come to the program, they have to go for upfront CB-NAT test. So this CB-NAT will show whether the MTB, that is Mycobacterium tuberculosis, detected or not detected, as well as resistance to rifampicins, whether rifampicin resistance detected or not detected. So suppose rifampicin resistance not detected, that is RSTB, RIF sensitive TB. So that patients, then next we have to collect the sample for first line LPA. So that is rifampicin sensitive TB. We have to collect first line LPA and simultaneously start the drug sensitive TB regimen. And among this first line LPA, it shows again MTB detected or not detected, as well as resistance to isoniazid as well as rifampicin. Suppose if isoniazid is sensitive, that is H sensitive. So already we started the DS TB regimen. Please continue the drug sensitive TB regimen. Suppose if the first line LPA report shows H resistant, that is isoniazid resistant, stop the DSTB regimen. Then this is labeled as H mono or poly resistant TB regimen. So we have to start the mono or poly resistant TB regimens and simultaneously look for additional resistance and with the second line LP and liquid culture DST, and look for if suppose non-availability of drugs or intolerance, emergence of any exclusion criteria, then the regimen has to be modified as per replacement sequence which has been described later. Suppose if the CB-NAT shows MTB detected and RIF resistant, or first line LPA shows RIF resistance, then this patient, again the sample has to go for first line LPA, second line LPA and liquid culture DST. So if these reports shows INH resistance but only INH-A or CAT-G, not both, as well as FQ and SLI sensitive, that is left side of the algorithms. So if INH any one resistance, that is INH-A or CAT-G, or FQ and SLI sensitive, these patient has to undergone shorter oral bedaquiline containing regimens. Suppose second line LP and LC DST shows INH both INH-A and CAT-G mutations, or FQ or second line injectable resistance. These patients should undergo longer oral MDR or XDR TB regimens, and again if any regimens, any additional resistance or non-availability of drugs, intolerance or any exclusion criteria, modify the regimen as per replacement table. So it has been discussed in subsequent slides. So this is the integrated DRTB algorithm. So currently we have only 4 regimens in the programs, and among the 4, the first 3 has been already rolled out. That is shorter oral BDQ containing MDR or RTB regimen, longer oral MDR XDR TB regimens, isoniazid mono poly DRTB regimen. These 3 regimens has been rolled out. Whereas bedaquiline pretomidate linezolid regimen, BPAL regimen has not been rolled out in the programs till now. So now we come to the shorter oral BDQ containing MDR or TB regimens. So this regimen contains intensive phase as well as continuation phase. The initial intensive phase will be 4 to 6 months and continuation phase will be the 5 months. So, the total duration will be either 9 months or to 11 months. The initial intensive phase, that is 4 months, initial 4 months contains 7 drugs like bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH and ethionamide for initial 4 months, followed by the next 5 months levofloxacin, clofazimine, pyrazinamide and ethambutol. So, this is if the IP is not extended, that is initial 4 months 7 drugs followed by 5 months 4 drugs, among which the bedaquiline only will be given on the 5th and 6th month. So, except all other drugs in the IP phase will be stopped, then the initial 4 months contains all 7 drugs, followed by 5 months levoflox, clofazimine, pyrazinamide and ethambutol started from 5th month to 9th month, among which the bedaquiline only will be continued from the intensive phase to 5th and 6th month. Suppose if we are continuing the intensive phase for 2 more months, that is instead of 4 months we want to continue 6 months based on the smear and culture reports, then all 7 drugs has been continued for 6 months, that is bedaquiline, levoflox, clofazimine, pyrazinamide, ethambutol, high dose INH and ethionamide, followed by remaining 5 months levoflox, clofazimine, pyrazinamide and ethambutol. So, in this regimen there is no change in the duration as well as compositions. Suppose we want to modify the regimen in place of using other drugs, replacing, or if you want to modify the duration, it is not accepted. So, in that situations we have to evaluate for the longer oral MDR XDR TB regimens. So, the inclusion criteria for shorter oral BDQ regimen will be those biological specimen which shows rifampicin resistance, as well as MDR or RRTB with H resistance, either INHA mutation only or CATG mutation only but not both, or and MDR or RRTB with FQ resistance not detected. So, these will be the inclusion criteria. Exclusion criteria. Suppose MDR or RRTB with H resistance for both mutation, INHA mutation as well as CATG mutations, or MDR or RRTB with FQ resistance has been detected, history of exposure for more than 1 month to the following drugs like bedaquiline, levoflox, ethionamide and clofazimines, intolerance to any drug or risk of toxicity, pregnant and lactating women, children less than 5 years, extensive TB and extrapulmonary TB. These are all the exclusion criteria for shorter oral BDQ regimens. So, need for stopping or replacing any drug in the shorter oral BDQ containing MDR or RRTB regimen warrants stop the regimen. Evaluate the patient to switch to longer oral MDR or XDR regimen. So, this is shorter injectable containing regimens, it is again 9 to 11 months durations, but actually now the oral regimens get scaled up nationwide, the injectable regimen will be phased out slowly. So, hereafter we prefer only oral BDQ containing regimen only. So, the preliminary report shows 13% higher treatment success rates among the shorter oral regimen compared to shorter injectable regimens. So, now I come to the longer oral MDR or XDR TB regimens. This is the 18 to 20 months duration of levofloxacin, bedaquiline, linezolid, clofazimine and cycloserines. What is the eligibility criteria for longer oral regimens? Those that is MDR or RRTB patients who are excluded from shorter oral BDQ regimens will be the inclusion criteria for longer oral MDR XDR-TB regimens. So, how this regimen is formed? Actually, based on efficacy and experience of previous usage of these drugs, the WHO consolidated guidelines for TB module has been formulated. So, based on this, they have been tabulated, grouped drugs into 3 groups. So, group A contains levofloxacin or moxifloxacin, bedaquiline and linezolid, that is 3 drugs, and group B clofazimine, cycloserine or terazidone. So, usually terazidone not available in the programs, and group C drugs ethambutol, delamanid, pyrazinamide, imipenem cilastatin or meropenem, amikacins, ethionamide or prothionamide and paracetamol salicylic acids. So, how the regimen will be formed? So, actually when forming the DRTB regimen for longer oral, we have to take minimum 4 to 5 drugs to form the regimen. These 4 to 5 drugs we have to prefer group A and group B drugs. If possible, try to utilize 3 drugs from the group A and 2 drugs from the group B. So, totally it forms 5 drugs, that is the regimens levoflox, BDQ and linezolid from the group A, clofazimine and cycloserines from the group B. So, this is the devised regimen. Suppose if any additional resistance or intolerance or toxicity or some other exclusion criteria, we have to take the remaining drugs from the group C. And there has been order for this, I will come to that later. So, the longer oral MDR XDR TB regimen, the total duration will be 18 to 20 months. There is no IP and CP. So, all 3 group A agents, that is bedaquiline, linezolid, levofloxacin or moxifloxacins, and at least one group B agent should be included, that is clofazimine or cycloserine from group B. So, at least minimum we have to 4 drugs. Suppose if only 1 or 2 group A agents are used and both the group B agents are to be included. If the regimen cannot be composed with the agents from groups A and B alone, then we have to take the drugs from the group C. So, here the dose of linezolid will be tapered to 300 mg after the initial 6 to 8 months of treatment. So, initially it has been 600 mg, followed by it has to be tapered to 300 mg. And bedaquiline will be given for 6 months, the initial 6 months only. And if needed extension beyond 6 months, it is in only in exceptional cases. Pyridoxine to be given to all DRTB patients as per weight bands. For both pre-XDR and XDR-TB patients, the duration will be 24 months. So, after 6 months of treatment, the patient must be reviewed based on 5th month culture reports. Suppose if 5th month culture report is not available, decision to taper the dose of linezolid to 300 mg will be based on the 4th month culture reports. If 4th or 5th month culture results remains positive, the dose of linezolid, that is 600 mg, and the regimen is extended by 1 month for a maximum of till 8 months. So, the minimum duration will be 18 months for MDR or RRTB, but we can extend 2 months based on 4th or 5th month culture reports. If the 8th month culture is also positive after extension, subject the culture isolate to first line, second line LPA and liquid culture and DST. If any additional resistance to group A, B or C drugs in use is detected, reassess for modification of longer oral MDR XDR TB regimen. So, the duration of bedaquiline is limited only 6 months. Extension beyond 6 months is to be considered in patients in whom an effective regimen cannot be otherwise designed and if only 2 of 5 drugs are available from the group A, B and C drugs. So this will be the replacement sequence. Suppose we cannot able to form the regimen with the group A and B alone, we have to take the drugs from the group C in the following orders. First delaminate, then amikacins, then pyrazinamide, ethionamide, PAS, ethambutol and penums in the order of sequence. But always prefer the regimen will be the fully oral regimens. In certain circumstances, we can go for injectables if no other options available. So, in situations where no replacement of any drug is required in the first 6 to 8 months, the treatment in MDR and XDR-TB patients continue with at least 3 drugs of any one of group A or group B drugs after this depending upon resistance. In the final 12 months, at least 3 to 4 drugs are to be used from group A and B. In situations where this cannot be done, the remaining drugs from group C may be added. But don't add delaminate and amikacins in the last 12 months of treatment. So this is the tabular columns regarding the replacement. So it is very simple. So take 3 drugs from group A, 2 drugs from group B, that is the ideal one. If any one drug is not available or 2 drugs not available from group A or group B, go to group C in the order of preference which has been mentioned previously. In the order of first go for delaminate, amikacins, pyrazinamide, ethionamide, PAS, ethambutol and the penums. So this only has been represented from the tabular columns. So what is BPOL regimens? So this is a regimen of 6 to 9 months durations containing bedaquiline, pretomanid and linezolid. So this has been under operational research conditions in MDR-TB patients with TB that is resistant to quinolones. We have either no previous exposure to bedaquiline and linezolid or have been exposed for not more than 2 weeks, but does not apply to routine programmatic use. So it has not been rolled out in programs till now, and this regimen shows 90% favorable outcomes among the XDR-TB patients and 89% with MDR-TB with FQ resistant, that is pre-XDR, and treatment on non-responders it has 92% outcomes. So when to consider? So pretomanid is approved by DCGI for use as a part of BPOL regimen for conditional access under NTEP. In exceptional cases where an effective longer oral MDR XDR-TB regimen cannot be designed with the available drugs, NDR, that is nodal DR-TB centers or state difficult to treat TB clinic, may send their case to National DT3C for clinical decision support and recommendations for BPOL. The initial hospitalization is required for initial 15 days at nodal DR-TB center ward for close monitoring of tolerance. Active pharmacovigilance and proper management of adverse drug reactions and prevention of complications from drug-drug interactions is also important. Drugs to be made available by NTEP through state drug stores to nodal DR-TB centers and refill to be done by nodal DR-TB centers on monthly follow-up visits by the patients. So few facts regarding the newer drugs like bedaquiline and the delaminate. So bedaquiline is a diaryl quinolone that targets mycobacterial ATP synthase, which has bactericidal and sterilizing activity against MTB, which shows significant improvement in time to culture conversion in MDR-TB patients. So additional requirements, so especially for females advised not pregnant or willing to practice birth control methods during treatment or have been postmenopausal for past 2 years, then only we have to consider BDQ regimens in females, as well as patient with controlled stable arrhythmia to be considered after cardiac consultation. So before starting the BDQ regimen, we need cardiac evaluations to look for any arrhythmias or QTC prolongations, then only we have to start the BDQ regimens. So, delaminate, it is a nitroimidazole group that targets bacterial cell wall, so which has been introduced in India in 2018. So, it has been used in adults having pulmonary MDR-TB and not eligible for shorter MDR-TB regimens, but now it has been recommended even up to 3 years delaminate can be used, but below 3 years it is not accepted. So, special caution needed in those patients with HIV positive, more than elderly patients, more than 65 years old, diabetes, hepatic and severe renal impairment, and serum albumin less than 2.8 grams per deciliter are those who use alcohol and other substance abuses. The dosage is 100 mg BD for 6 months along with underlying optimized background regimen. So, now we will go to INH mono poly DRTB regimen. The inclusion criteria will be INH mono poly DRTB with confirmed result for rifampicin resistance not detected. So, the exclusion, there is no specific exclusion criteria. The regimen contains 6 to 9 months levofloxacins with other first line drugs like rifampicin, ethambutol and pyrazinamide. In exceptional situations of unavailability of loose drugs of rifampicin, ethambutol, pyrazinamide, we can use 4-FDC along with levofloxacin tablets. Suppose if loose drugs not available, we can use 4-FDC along with levofloxacin. So, the duration, there is no separate intensive and continuation phase. The 4 drugs will be continued for 6 or 9 months. The replacement sequence, suppose if levoflox cannot be used, that is if resistant documented, we can use high dose moxifloxacin if second line LPA pattern shows sensitivity. If high dose moxi or pyrazinamide cannot be used, we can replace with linezolid, or linezolid also cannot be given, we can replace with the clofazimine or cycloserine. If both high dose moxi and pyrazinamide cannot be used, add 2 drugs of following 3: linezolid, clofazimine, cycloserine in order of preference based on resistance, tolerability and the availability. Suppose if our resistance has been documented, should switch over to shorter or longer MDR or RTB regimens. So, wherever the levoflox, that is initial 4 drugs, levoflox REZ cannot be used, in other situation use the duration for 9 months. So, this is the dosage of drugs of DRTB. This is usually based on weight bands. We have 4 weight bands: 16 to 29 kg, 30 to 45 kg, 46 to 70 kg and more than 70 kg. And some of the drugs like quinolones, levoflox and moxifloxacins and ethionamides, cycloserines and PAS can be used in 2 divided doses in case of intolerance. And pyridoxine to be always given for DRTB patients less than 30-50 mg, more than 30-100 mg. So, the bedaquiline dose, so whatever the regimen, the bedaquiline is continued for 6 months only. The initial 2 weeks is 400 mg along with the optimized background regimen. Following 3 to 24 weeks, 200 mg thrice weekly. So, CYP3A4 inhibitors and inducers statins to be avoided during bedaquiline and up to 1 month after last dose of bedaquiline. So, a simple algorithm for management of DRTB patients during pregnancy. So, whenever patient diagnosed as DRTB and pregnancy, if less than 20 weeks, advise MTP. If MTP done, we can give or we can continue shorter oral BDQ containing MDR or RTB regimen. Suppose patient not willing for MTP or more than 24 weeks. Suppose if it is less than 32 weeks, start or continue longer oral BDQ containing MDR TB regimens. If more than 32 weeks, we can go for longer oral BDQ regimens, or we can go for shorter oral BDQ regimens. It has been discussed based on the decisions between the treating physicians and the obstetricians. A simple algorithm for childhood DRTB management. So whenever the DST, that is, or DRT is available, if it is confirmed as DSTB, treat as DSTB. If DRT DST shows drug resistance, treat as like adult DRTB. Suppose DST DRTB of the children's age group not available, try to identify the contact source of the pediatric TB patients. So identify the contact source, and among the contact source try to identify the DST or DRT pattern. If available from the contact source, based on that we can label the child as DSTB or DRTB based on the source contact. So simply try to get the biological specimens from the children's to diagnose DS or DRTB. If it is not available, try to identify the contact source, get the biological specimens and document that whether it is drug sensitive or DRTB from the contact source, treat accordingly. So again, the dosage for pediatric TB patients is mainly based on the weight only. So at present the delamanid is not advisable for less than 3 years, and bedaquiline is not advisable for less than 5 years. So all other drugs can be used along with the consultations from the pediatricians. So these are all the key facts. So always consult with an expert, pediatricians available or linked to DRTB centers. So include at least 4 to 5 effective medicines from group A and group B to which MTB strain is known or likely to be susceptible. Do not add a single drug to a failing regimen to avoid amplification of resistance. Strict monitoring of treatment by clinical examinations, radiology and culture response to be undertaken by pediatricians and experts and available or linked to DRTB. So always prefer child friendly formulations, try to avoid injectable preparations. So thank you.